And the first one is glenohumeral, and to best see that, you got to turn to page 542. And I want you to see kind of how the internal aspect of that looks. This is just a really unique view because it removes the humerus and it shows you the glenoid fossa being that concave surface, but it also gives you some really unique views of the muscle, specifically the rotator cuff. And what you can see there is it's very thin, isn't it? And that's really a true depiction of how thin that muscle is going around it. And so if there is a tear in that muscle, it can be very substantial. We'll get into that on Wednesday. Also, though, just kind of take a look at some of the other things that go along with that, maybe like the biceps brachii tendon and how it inserts at the glenoid rim, right? You see that picture? And then we have something called the labrum. The labrum is best thought of as a ligamentous tissue that encapsulates around the glenoid and the humerus. The triceps comes in even up there at the top of the humerus. And then if you turn back, you see another picture on page 540. And that's a little bit better picture for looking at ligaments. But take a look there. You have a glenohumeral ligament. And it breaks it down into superior, middle, and inferior. But also take a look at the coracohumeral ligament, right? So again, what we talked about in seminar, we said these ligaments, they're named as such for the bones that they connect. So many times if you see a connection question, or a ligament question, then just think of what are they connected? And then try to cipher out where you can go from there. Jump into the next one, the acromioclavicular is identified very well there. And I know Bill spent some time talking with you in anatomy about these ligaments right here. But you know, the big one, the acromioclavicular ligament that spans between the clavicle and the acromion. But then the coracoclavicular ligaments, just take a look for me right there at the trapezoid and the conoid. And one of the things that we'll talk about before we conclude today is how those ligaments bind that clavicle down. And what happens when the injury is so severe that it ruptures these three ligaments, and we'll kind of see that mature through the phase. Another one, though, turn the page over to 542 and take a look at your sternoclavicular joint. And just be kind of familiar with the way these work in these ligaments here. And there is your costoclavicular ligament. Remember, we looked at that one in seminar and we said, well, gosh, where would that ligament be? And again, that's at the rib and the clavicle. But there's your picture of it right there. How it moves from the rib up to the clavicle. And again, that's the first rib. So a lot of unique joints, muscles, go into this whole concept. So let's move into some functional articulations. First of all, let's talk about motions of the scapula. On Wednesday, we'll begin to look at how we can mobilize that scapula from a passive or an external control point. One of the things that we're going to tell you is, remember, the scapula does have elevation, it does have depression, it does have protraction, it does have retraction. All of these identified over on page 543, and you see those, and you can kind of consider what those movements are. And then we want to talk about something called postural relationships. And that's on the bottom of page 543. And it says, in the dependent position, the scapula is stabilized primarily through a balance of forces. And so that includes the weight of the arm and forward tilting moment on the scapula. And if you look down at the, skip a paragraph and you look down at the faulty posture, it gives you a really good picture of what we're seeing there down at the very bottom of that page, figure 17.6. And when that head goes forward, what that does is that allows for that kyphosis to form in the thoracic spine. And when that kyphosis forms, what we see there is a protraction occur, right? And that comes from the weight of the arms going forward, pulling that whole scapulothoracic area forward. And that's kind of the thing that we want you to walk away from, is seeing that. But also, take a look, a little bit of internal rotation occurs at the humerus, right? And then a downward pull on that humeral head. And this is just kind of that faulty posture look. So as you kind of go forward, think about what does happen there. And if you saw that, what would you think we would need to do? We would need to strengthen what?
Posterior muscles.
Okay, which one specifically?
Middle trap, rhomboid.
I like middle traps and I like rhomboids. You know why? Because they're retractors. Right? So we want to pull that up. What else would we want to do? We want to get the upper traps too, right? And this also gives us a good look as to why we want to bring in those pec minor stretching, right? Think about what that pec minor is doing, pulling that forward. And if you go back and you look at the scapula and you think about what the pec minor and how its attachment is, it gets a tight weakness, right? And so we know now, after just taking that test this morning, that we have to strengthen those in a lengthened position, which means they have to be retracted scapulae, and then that's when we start to strengthen those. Otherwise, we strengthen them in a shortened position and they just get shorter. So we don't want that to happen. And now, if you're feeling really good about that, we have to turn the page over and we have to look at this one little item right here. I know Bill talked to you about it. It's called scapulohumeral rhythm. And that's at the top of page 544. And so let's just go to the book and let's just see what it says there. It says, actually it's at the bottom of page 544, it says the ratio has considerable variation among individuals, but is commonly accepted to be a 2 to 1. 2 degrees of glenohumeral motion to 1 degree of scapular rotation. So, let's break this down. It says during the setting phase, 0 to 30 degrees abduction, 0 to 60 degrees flexion. Motion is primarily at the GH joint. That is from the humerus moving on the glenoid, right? And the scapula seeks a stable position. During the mid-range of the humeral joint, the humeral motion, the scapula has greater motion, approaching a 1-to-1 ratio with the humerus. But what we know is that that's on most people, and this is what we're going to go with on the book, 2-to-1 ratio. 2 degrees of glenohumeral to 1 degree of scapular motion. So one thing we kind of have to do is we go in on Wednesday and we say, we need to move that scapula. It needs to be mobile. And we'll really see this at the end of the day when we start talking about a frozen shoulder.
Real quick, you know how you said one thing, what was it? A tight weakness has to be strengthened in a lengthened position, so
Yes.
it's opposite for short lengthened weakness. Strengthened weakness.
Stretch weakness.
So do you know what I mean? Like, do you go to a short range?
No, this is more applicable to that type of weakness. It's just kind of on. It's not like thought of when you think of muscle strengthening. We most commonly think of, let's just put that muscle to doing more shortening, right? The problem is, if a person does that to a tight pec minor, and they do it here, and they just So back here, this is, what did you call this? If this is a tight weakness,
Stretch weakness.
this is your stretch weakness, right? So here, it's already lengthened, right? So we want to pull, and as you continue to contract that, it will shorten on its own there. So it's just a one-sided philosophy, I guess you would want to say. So let's look at some referral patterns. This is at the top of page 545. One of the things that you'll notice is when you're treating shoulders, many times you'll be treating that shoulder, but it's because of a problem that is expressed in the shoulder. And here's a really good example. When you look there on page 545, it talks about the cervical spine, and it says vertebral joints between C3 and C4, or between C4 and C5, nerve roots C4 or C5. And so if there's a nerve root issue, what it does is it expresses itself distantly. And this is known as referred pain. And you've probably heard Ms. Hoppe talk a little bit about this. And so we look here and we see these referred pains from related tissues, specifically dermatome C4 is over the trapezius to the tip of the shoulder, and that's very consistent with the picture we have. But many people will come in and they'll say, you know, it's just, and they don't really say my neck all the time. They'll sometimes say my shoulder, but maybe they do say their neck. But what we know is if C4, as it leaves through that nerve root or through that lateral foramen, if there is any kind of compression there, many times their pain will come out right here. And where do you suppose C5 might show up? Where is it? Yeah. Right. And gosh, you know what? You can keep going on this. What about C6? Where's it going to show? Yeah. Well, even up at the top still, C5, C6, C6, C7. It just follows those dermatome patterns down, right? And so what we know is that anytime there is a nerve issue, and this is why we talk at the spine first and then come here, we can see that problem just persist into that shoulder. I'm going to come over here and borrow Dakota real quick. Dakota, can you slide your chair up for me? And just turn and face your peers there. So when I was in school, a special test that I learned was called the Sperling's maneuver. And so you can see this. Now, whether or not you remember the Sperling's maneuver or not is irrelevant. But take a look and let's just see if you can kind of follow the tracking here. The Sperling's maneuver is performed by taking a patient, identifying a painful side, and then what you're going to do is you're going to put them into just a little bit of extension. You're going to rotate away from and tilt back even more into that. And then I just do a little bit of compression on top of the head, axial loading, if you will. And if that nerve root is impinged, this recreates their symptoms, right? You see how that would work? If I axial, so I'm pushing down right here, right? See it? And then the same thing is true if I turn here, tilt back, and a little bit of side flexion, and there, right? So it's called Sperling's maneuver. Whether you remember that or not is irrelevant, but think about what we're doing there. We're compressing down on those nerve roots.
What are you trying to accomplish with the rotation and extension? Are you trying to like tighten?
You're just trying to maximize the compression down over the intervertebral foramen. Because what happens then is you really close that down. And almost, if they do have a nerve root impingement, by the time you do this and that, they're like, whoa! And then you, boom! And they say, yes, that's it. And what that does is that just compresses that nerve going out. And that's where you get the referral pattern. So how are you feeling about that? You're just compressing that tissue, trying to reproduce those symptoms. That's the whole deal on a special test. Thank you, sir. Another one, though, is the diaphragm. Pains perceived in the upper trapezius region. I would just put that down, not for me. That's not a test question for me. I'm not going to do that one, but I am going to throw that one at you. If they have a diaphragm involvement, they can have pain up into their traps. That would be like a really nasty question on your licensure exam, wouldn't it? Here's one that you've probably seen before. If they're having a heart issue, they can have pain perceived in the axilla and left pectoral region, right? And so that's that left shoulder pain. It has nothing to do with their shoulder, does it? It's all about their heart, but it's a referral pattern up to the shoulder. And in the gallbladder, pain perceived at the tip of shoulder and posterior scapular region. Now, I want to hit a pause button, and I want to double click on something. I just said I'm not going to test you on this in Therex. I did not say anything about score builders. Or, I'm sorry, about seminar. You might just kind of look at the fact that there are four specific levels right here, right? Associated with 4 specific regions of where pain goes to the shoulder, or the shoulder region. And I would just kind of keep those in mind, because I promise you, you will see that again, just not in Therex. Because that one right there has licensure exam written all over it in my mind.
Where did you say the gallbladder was?
Gallbladder irritation, pain perceived at the tip of the shoulder and posterior scapular region.
Angina pectoris is chest pain, right? And does it only happen on the right side?
Angina is a left side.
It happens on the left. Okay. But it's not the actual heart, though, is it?
Yeah, it's a ischemic event.
Oh, it is.
And while we're at it, angina is also stable or unstable. Stable meaning, I know if I climb that flight of stairs right there, I'm going to have chest pain. And I'm going to need to get my nitro. Unstable is, I'm just out doing my thing, never experienced any problems before, and bam, all of a sudden I have chest pain. Is it a heart attack? No, not in this case. It's angina. Angina. I always struggle. Is it angina or angina? I don't know. I've heard it pronounced both ways. But it's an ischemic event, nonetheless. That's a good question. Glad you asked that.
So it is stable? Is it stable or unstable?
Okay, so we're gonna let's keep our timeout going. Let's do it this way. You have stable and you have unstable. You have 2 different types. This one says you can predict when it will happen by virtue of an activity. And then this one is unpredictable. No idea when it can happen. I mean, that could happen anywhere from walking to sexual activity to, watching TV. The whole gamut right there, right? This one right here, I know that if I walk at this pace for this long or go up that flight of stairs, I'm going to have angina. There's your cardio foam lesson for the day. nerve disorders. Now, real quick here. Your book says nerve disorders. Really what I want you to do is I want you to go over there and somewhere in your notes or even in your book, this identifies 3 compression injuries of nerves that we see at the shoulder. So rather than having a nerve root injury, this is a nerve injury, right? So take a look at our picture up here. Right? So you have your nerve roots leaving the spine. Everybody's good with that word, right? The root leaves the spine. We're not talking about nerve roots, that's what we just did. This is the middle of the nerve got a compression injury. And the first one that we look at is thoracic outlet syndrome, identified by a test known as RUSE. Remember we talked about that one right here? And then we had a test where they turn their head and we look for a pulse, and then they turn their head and we look for a pulse. And what we're looking for is if there is a compression over that bundle. It says under the first part, common sites for compression are the scalenes, costoclavicular space, and under the coracoid and pec minor muscle. So just think about how that thing leaves passes through the scalenes, under the costoclavicular space, and take a look at the coracoid and a pec minor muscle.
Kendall, what page are you on?
I'm on page 545 under nerve disorders and disorders. All right, so here's the next one. And in the second bold area, it says the suprascapular nerve and the suprascapular notch. This injury occurs from direct compression from a nerve stretch, such as when carrying a heavy book bag over the shoulder. Right here is your suprascapular notch. It's just a nice little notch in the back end of that scapula. Kind of awkward to see. Not really probably something Bill talked a lot about, but maybe he did. Maybe Miss Hobday talked a little bit about it when she talked about the suprascapular nerve, right? And so that's a really good way to remember that nerve getting hammered by our book bags.
Where does the supraspinatus run through there?
Yeah, the supraspinatus is right there. Okay, so there's the suprascapular notch. And then one more. And that's when we see people leaning on crutches. And you've probably heard us tell you this since intro, right? We don't let our patients lean on our crutches. Here's the reason why. Because that crutch finds its way into the axilla, that's our armpit, and when it does, it can compress the radial nerve. The radial nerve is vulnerable to a compression injury, very specifically when we lean on crutches. It says, brachial plexus in the thoracic outlet, suprascapular nerve in the suprascapular notch, radial nerve in the axilla, all being compression type injuries. And then what you would want to do is you would want to backtrack to neuro and say, okay, what do those nerves go to? Because if they're compressed, you're going to have a palsy or a paresis, all words you're familiar with now, in that muscle that is innervated by those nerves. How you feeling? Is that okay?
I'm thinking the brachial plexus was affected in thoracic outlet, so, but it's not every muscle that the brachial
Right.
plexus.
Yeah, it would be where at, and that's really the unique thing, because if you look at thoracic outlet, it had 3 distinct areas where we see most commonly that happening. And so it could be in any one of those areas, and then you look distantly from there. What I can tell you is my experience with thoracic outlet, or brachial plexus, not thoracic outlet syndrome. Let's do brachial plexus. Is it's come from an injury, and I do need to kind of break into this, called a neuropraxia. And this is probably a word we haven't talked about in a while, but let's just kind of review it. Neuropraxia is like just enough, and your book said this, but I'm gonna reiterate this. It said it's a stretching, where the nerve is stretched. Well, think about this. If a nerve is compressed, it is stretched. It's just like when you roll a tissue, a muscle, you stretch that. So think of it kind of in the same way. The brachial plexus can be stretched when the head is pulled over and the shoulder is depressed, right? That's called a neuropraxia. But if the tissue, specifically the nerve, is damaged more, and it damages the axon, it's known as an axotomesis. And if it's completely ruptured because of that tension, it's called a neurotomesis. And you might remember those words from physical disabilities: neuropraxia, axotomesis, and neurotomesis. And it's just that level or grading of injury. The brachial plexus can be stretched in such a way in sports many times, and it's either called a stinger or a burner. And that's just the way it got its common name. And what they do is they walk up, and you can see it coming. They just kind of have this palsy, it's almost like this, not atrophy, but they just kind of have this hemophoresis, basically, where they walk up and they're like, so I got a burn. And you're like, I can see it, because they're holding this side up normally, but this side's just kind of droopy. If you've ever watched a football game where football players ran off the field kind of like this right here, and their arm is just kind of dangling, it's because it's kind of dangling. There's no sensation going to it. And they get to you, and they can't flex, abduct, externally rotate, nothing's really working. And so you see it there, and then you can track it down. Because if they can't flex, it's probably at C5. Right? If they can't shoulder or elbow flex, where's it at? C6. If they can't resist their triceps, if they can't extend their wrists, right? So you can track it down. I mean, it's amazing when you see one, and even in the thoracic outlet being the same way. You can track it right down and know exactly what nerve is going to do. It's impressive.
And so if someone gets done with a stinger or whatever, do you just do, what do you do?
You start with passive range. You, by virtue of that injury, you do the things, you maintain their mobility with passive range. You work with adjacent tissues, and you wait for healing to occur. And as it does, that's when you start with isometrics, and then you bring in the All right, so let's talk a little hypomobility. Now that word right there means they don't have mobility, right? It's restricted. So with that, your book talks about on 546 4 very specific conditions. Number 1, rheumatoid arthritis. So with RA, it says specifically to look in chapter 11. So we're going to kind of just pretend that we know what chapter 11 talks about with RA, but that means probably they have symptoms in both shoulders, right? Now, if it's osteoarthritis, that means that they have pain in one shoulder, not two. And we're going to kind of look at osteoarthritis and interventions for that here in just a few minutes. But this is not osteoarthritis, it is not RA. Let me say that again. What we're going to talk about here in a minute is not osteoarthritis and it is not RA. It also talks about traumatic arthritis, meaning that there was some trauma and now you've developed some arthritis. So they've really pushed into, listen, arthritis can be primary or it can be secondary, and they're just reminding us of that. And then in the third, it says post-immobilization arthritis. What does that mean?
After you have moved it.
Exactly. Yeah, you've been in a sling, and now you start moving, and it doesn't move very good. And we'll kind of talk a little bit more about some of those as we go through. But take a look at the fourth. This is the one that we need to kind of hit a little bit more, and that is a condition known as adhesive capsulitis, also known as frozen shoulder. Everybody good with those two terms? Adhesive capsulitis, also known as frozen shoulder. Now there's a word before frozen shoulder. Who can tell me that word in big bold? Idiopathic. What the heck does that mean? I don't know. I love that word. It's probably like my favorite word in medical term. I love it because I'm like, it's just idiopathic, and they're like, what's that mean? I don't know. I mean, that's just the best way to say it. You don't know. We have no idea where it came from. My sister-in-law, she had an idiopathic frozen shoulder back, I would say, 5 or 6 years ago. She was in our pro bono, but this is even more than that. This is way before we moved over here, I remember. And she came to pro bono clinic, and our students worked on her, and they did a lot of these things that we're going to talk about right here, and they got her falling. How about that? A few weeks ago, well, no, I'm sorry, not a few weeks ago. A few months ago, the same sister-in-law went through her dose of COVID-19. And after she finished her dose of COVID-19, a few weeks later, she's like, man, my shoulders hurt. And it's almost like she was identifying a septic arthritis. Meaning like she had an infection and it caused her joints to hurt. Well, what's COVID-19? It's an infection. And she kind of came back, and so she went back to her doctor, and the doctor's like, yeah, we've been seeing this lately. People are coming in, they're saying that these old injuries are reflaring, basically. And she had another dose of frozen shoulder come up. But it came from what they think was a septic version from COVID-19. So it was just kind of an interesting way of going through. It says there in that paragraph that it's characterized by the development of a dense adhesion, capsular thickening, and capsular restrictions, especially in the dependent folds of the capsule rather than arthritic changes in the cartilage. Now, really pay attention to that. The book disassociates arthritis and adhesive capsulitis. They're not the same thing. So you need to be aware of that. And in this picture right here, in your slides or on your handouts, what I did was I wanted you to really look at what a normal capsule looks like versus an adhesive capsulitis. It is the capsule, not the joint. So if you'll indulge me here, if I were dealing with the glenohumeral joint, right? I would have a nice articular cartilage on both of these surfaces. If that cartilage were to begin to fibrillate and possibly loose bodies start floating around from that cartilage, or possibly even eburnate, where it got nice and smooth. Again, those are words we haven't talked about in a while. Physical disabilities words. Eburnation, fibrillation. These are the two defining terms osteoarthritis. That is not what we see happening here. This is of the joint capsule. And so it's critical that we don't try to put these two together. They're not the same. So back up here, it says, number one, it's idiopathic. That means we don't know how sometimes it happens. But number two, it talks about an adhesive capsulitis. It's in the capsule. It is not OA. And then number three, I want you to see here, is it could be caused by primary or secondary reasons. And so let's just diversify that for a second. It says the onset is insidious and usually occurs between the ages of 40 and 60. Listen, I don't care that you know that. I don't care that you know 40 to 60. But it might help out later. It says primary frozen shoulder just happens idiopathically. We have no idea why. But there's another version called secondary. And that usually comes from a traumatic issue. Maybe you did have osteoarthritis, and then you got a frozen shoulder. Maybe you did have a dislocation, and you stayed like this for a long time. Or maybe your job keeps you like this right here. Or you just did nothing at all differently, and you got a frozen shoulder. So we don't know. Look up at clinical signs and symptoms. I'm sorry, before you do that, faulty posture and muscle strength imbalances may be consistent with this, predisposing the individual to impingement or overuse syndromes. But take a look at our stages now. Stage 1, 2, 3, and 4. Just take a look at what it says. Number 1, it's gradual onset of pain that increases with movement. Stage 2, it gets a little more persistent, more intense, even at rest. But by stage 3, this is the one where we say, nope, it's frozen. And it has significant adhesions and limited GH motions with substitute motions at the scapula. Here's what a substitute motion at the scapula looks like. Oh yeah, I can get my arm up like that. Right? They don't, they lock up. And so they have to get this big trunk lean to get their arm up at 90 degrees. It's not really at 90 though. But here's the really cool part. Well, before I do that, atrophy of the deltoid, rotator cuff, biceps, triceps, brachii, all may be noted. But then if it just keeps going, some cases are characterized by minimal pain and no synovitis with significant capsular restrictions from adhesions. Motion may gradually improve during this stage. So they may just pop out of it. Again, idiopathically, they may just kind of come out of it. And we like to say that that's probably just some healing coming along from the body. Some impairments, take a look at these on page 547. Night pain and disturbed during acute flares. Now, right there, just so we know, most people with shoulder problems have night pain. Why do you suppose that is? You're laying on it, and it's just a really difficult thing to deal with. The shoulder is historically bad at dealing with sleep patterns. It's just a really tough thing for people to deal with. Pain on motion and often at rest during acute flares. That's pretty common sense right there. But take a look at mobility. Decreased joint play and range of motion, usually limiting external rotation and abduction with some limitations of internal and elevation and flexion. So here's the deal. With a AC, adhesive capsulitis, not acromioclavicular, then they're mostly impaired with external rotation and abduction. Mostly. But they also have some flexion issues too. They have a pretty faulty posture. They have a decreased arm swing and gait. So here's what they do. Better not wear your step counter on that arm. not gonna get anything, right? They'll just really decrease it. And so, just jumping out there, kind of early here, but as the therapist, maybe you say you've got to be intentional, meaning put your brain on it, and do an arm swing when you walk. And hey, what about using walking as a modality in your treatment? And just having them do arm swings through walking? Because they can do that quite a bit. I mean, like if a person gets 10,000 steps a day, that also means that they probably got 10,000 arm swings a day, correct? So that's a pretty good deal. So you just did 10,000 mini oscillations in that arm. That's terrific. Muscle performance, generally muscle weakness and poor endurance with overuse of the scapular muscles leading to pain in the traps because they're kind of holding it up a lot. Some common activity limitations, they can't reach overhead. So here's what your job is say, listen, use your good arm and move the stuff that you need down low. Karen says, how am I supposed to comb my hair out in the mornings? Right? Because A, abduction hurts and external rotation hurts. So you think about it. What do you do for them? Are they able to brush their hair? Like, that's a big deal. It's not a big deal to Kari and I, but it's a big deal to them, right? So what do you tell them? Also, difficulty in dressing, reaching hand into back pocket of pants to retrieve a wallet. Man, I don't know. Are there any guys in here that still keep their wallet in their back pants in the back pocket?
I like to keep the form.
The what?
I like to keep the form of my wallet.
The form?
Good square.
You want the square in your back pocket?
No, I don't put it back there.
I'm so confused. What now?
I don't put my wallet in my back pocket so it keeps the form.
Ah, okay, I'm with you now. I was totally lost. Y'all all give Bill Carroll a hard time for keeping his wallet in his back pocket. And say, you're like the last person to do that.
He carries around a backpack. I don't know why he doesn't put it in there. I do the same thing.
He sits down looking like that?
Yeah.
Let me get my hips and knees into a flexion contraction, right? Suprascapular notch impairments. And he's gonna put his, we're gonna have to give this guy an overhaul now. Y'all go tell him. I'll let you do that.
Like your wallet in your back pocket, doesn't it like lead to back issues? You gotta,
The people who sit on the wallets that are that thick,
I mean,
who's
my
got a
dad's
thick wallet?
My dad's wallet is like this thick.
You got a thick, you got it with you?
Yeah, but.
Show off your thick wallet, come on now. Is it a front pocket wallet or a back pocket?
Never mind, I want a good tip.
Oh. That's what I tell everybody. Anybody got a thick wallet? Come on. Aaron, I thought you would be my guy.
This is mine.
I think I like this side is.
Your front pocket wallet?
Yeah, I just keep it in my backpack.
Yeah, some people, you're gonna run into some older guys who still carry like they gotta like crush it down and stick it in, and then they sit like this.
Yeah, they're gonna
You
end
know?
up sciatic with me.
Or something. It talks about the reaching out a car window, using an ATM, self-grooming, brushing teeth, washing face, bringing eating utensils to the mouth. Oh, I love that one, right? You think about the kids, and Donisa she may be the only one. Like, I notice this a lot about my kids, is they have like pizza on their plate, and they lean down to it. And I'm like, hey, listen, we've progressed as a society. Pick up your pizza and take it to your mouth, but eat over your plate still. So I don't know. They have a hard time with me. Do your kids do that? Do they lean down to the bowl?
They won't.
Huh?
They won't. They might. I don't know.
You don't care as long as they eat and shut up, right? That's me too. I got you.
They snap, they stress me out.
And then limited ability to sustain repetitive activities, so their endurance is low. So keep in mind what we're working on there. During your protection phase, let's take a look here. Control pain, control edema, and muscle guarding. Now, don't look at your book. Give me just a second of your time. What can you do to control pain in the shoulder?
you know you can do to control pain.
Modalities?
Like what?
Still,
Give me,
ice
okay,
pack.
okay, yep. Like them all. And I'm even gonna take my pads, and I'm gonna put one right here, and I'm gonna put one right here, and I'm gonna hook them together. You ready for this? And then I'm gonna put one right here, and I'm gonna put one right here, and I'm gonna hook them together, and what's it called? There you go. And then I'm gonna put me a nice hot pack or a cold pack on there. If I were gonna use a hot pack, what kind of hot pack would you recommend me using? One that's like this, and this, and this, and it's really heavy? No, I'd use a cervical, right? They work perfect. See, you got all this down. You're good. Okay, so now, what can you do for edema? Say it again. Ice and tan. Hey, what about elevating my shoulder? It's kind of already done for me. Compression, I don't recommend compressing the shoulder. I really don't. Sometimes you'll see people putting an ice pack on with an ACE bandage. If you haven't seen that done before, let me know. We'll do that in the lab on Wednesday. I like to use a double link. In fact, no, just remind me. Would you remind me to do that on Wednesday? So you guys have seen it before. You probably have, but let's just review and make sure everybody knows how to do that. What about this? Muscle guarding. How are you going to help with muscle guarding? Now, you may have to review what was muscle guarding, but somebody's going to help you out here. Don't look at your book. Don't look at your book. Some people are looking at their book still. I know you're looking at your book when you're looking at your book, not me. What are you doing to prevent muscle guarding? Think about that now. There was a very specific intervention that we used to prevent muscle guarding. What's it called?
Was it joint modes?
I was thinking verbal reinforcement.
Well, we're dancing all around it.
I mean, you just got to kick your can one more
Visual,
time.
visual.
What you got? What you got?
Relax.
You do like massage? Does that help you?
Maybe the shoulder circles, is that right? Don't know.
Active range of motion. But guess passive range. Muscle guarding. I'll take a little bit of passive range, but there was one intervention that really leads to improvement over muscle guarding.
Gentle soft tissue.
It's close. All right, let me do this. Let me come back over here. Let's do this one. Can I get rid of our cardio pump talk for the day? Yeah. Remember, if we do. Now listen, I've heard this spoken. I've heard this spoken. And I've heard this spoken. I'm waiting on one more. Yep. For muscle guarding, also known as inhibition, you've got to get isometrics in. So let's just kind of keep going, and we'll see how this comes in. Turn the page over, 548. And again, those bullets are true. I'm definitely not telling you you're wrong. Don't think that. It says control of pain and edema and muscle guarding, and it gives you several bullets there. But as you get down to the very bottom, on page 548, the last bullet under that, take a look at what it says: gentle muscle setting to all muscle groups of the shoulder and adjacent regions. All right? Including cervical and elbow muscles because of the close association with the shoulder girdle. So it's a big deal. So right there, we're going to pause for a minute. And I want want you to grab your lab partner. And I want you to go through flexion, abduction, and external rotation using isometric contractions. Do 3 to 5. Go. 3 to 5.
You go into that's all. And then here. So yeah. Like that would be too much of that thing. Did you do that one too? You know, I think she's gonna have to go to the Muskogee Hospital. I think so. No. She's like, she changed a lot of her.
All right, so take a look. Take a look at what we're going to do here. Monica, may I borrow you for a moment? I just wash my hands. Okay, so here I am. We're talking flexion, abduction, external rotation. I'm going to stay in this one spot. All right? Remember, this is what they don't do well. This is what they don't do well. Those are the restricted movements. Everything is sore. It's guarded. Okay, so here I go. I just take support a little bit of elevation in the scapula just by pushing up a little bit. Okay, now I want you to push against my hand there. Nope, wrong hand. Hang on. Too many cues. Okay, I'm going to push right there. I want you to resist. Ooh, she's so strong. Calm down. Okay. How long does an isometric contraction last? Yeah, there you go, 6 to 10 seconds. Okay, and then I just come right here and I say, I'm going to push you right there. I want you to push out. Good. Okay, and then I just come over here and I say, go ahead and push out on my hand right there. And I stabilize, right? And that's all I'm doing. And so there I am doing my passive range. Flexion, abduction, external rotation. Hitting those easy motions, right? Take a look at how you can maintain your mobility. And, you know, before I do that, though, can I go ahead and jump down here since someone else is in the room to hear this? There's a really unique condition that happens a lot of times with these patients known as complex regional pain syndrome. Now, I didn't learn it as that. What did we learn that as?
RSD.
Yeah.
Like sympathetic.
Yeah.
We've talked about it.
So remember, that one right there comes along a lot of times with these patients. So look for that hypersensitivity, right? That's a big issue with them. And if that happens, you're going to have to change what you're putting your hands on, your contact points. That's a really big position. Now jump back up there. What is a precaution? If there's increased pain or irritability in the joint after use of the following techniques, either the dosage was too strong or the technique should be modified to decrease the range of passive movement or delaying joint glides. That just means if you really jump in there and they shut down even more, you went just a little too far, right? So you're gonna have to back up on that next treatment session. And under contraindications, if there are mechanical restrictions causing limited motion, appropriate tissue stretching should be initiated only after the inflammation subsides. So here's the deal. We already talked about this. They can't go up. Your brain's probably already going fast forward and saying, well, we got to stretch that tissue. Yes, you do. But if you do that early, you're only going to backtrack further. So don't shut them down even more. Give them some time. They're going to come around to it. Now, with that being said, maintaining soft tissue and joint integrity and mobility. Passive range, yes. Passive joint distraction grades 1 and 2, yes. Now a pendulum. Everybody standing back up. It's a pretty well-known fact that we're not going to let you leave this program not knowing what a Valsalva maneuver is. We're not going to let you leave this program not knowing how to do a right pendulum. How many of you guys have did pendulums in your clinicals? Now, how many of you had to have some correction? Come on now if you did. Nobody's willing to voice this one.
No, I did, I started to move it, she said just let it hang.
Okay, let's upgrade our strategy on that one. So, everybody find yourself in the pendulum beginning position. Now we just talked about spines in here. So if you're doing this, we're gonna get you, right? Okay, so we've got a nice neutral spine, right? You're gonna use your hips to initiate this movement of your shoulder. Everybody take a look at me. Here's what you don't do. All right, I'm doing pendulums. Ready? That's not a pendulum. You know what that is? That's you leaning over and doing horizontal adduction and abduction. Okay? Actively. A pendulum means I take my hips and I'm going to step out a little bit to get this moving. And I take my hips and I've got an elephant trunk, y'all. Okay? Holy Toledo, Donita, are you going to move that trunk or what? Come on now, get that elephant trunk to move. I got an elephant trunk. You guys didn't play games with kids or something. I'm telling you what. Get that elephant trunk moving. Come on now. Nobody's helping me out here. Get that elephant trunk to moving.
Call out Rosie too. She's on
Rosie,
the right.
I'm calling you out too.
Right, I'm just going the other way. I'm moving.
All right, let's talk about moving in the, we were in the transverse plane, correct? Oh, snap. Here we go with the sagittal. You ready? Get those hips to moving. If your hips ain't moving, you're not doing it right. Now here's what's going to happen on skills check day. All right, sir, we need you to do the pendulum. They don't know what that means. Even though they're pretty smart people, they don't know what that means. Please don't tell them to do Godwins. Even worse. You got to tell them, and you've got to cue them. Make sure you're using your hips. Like I'm totally going to expect to hear you say that. Right? And even like, see how I'm kind of raising up on my heels and my toes? Right? Now this works better. I want to file myself when you have a little bit of weight. Okay? And why is that?
Momentum.
Exactly. Yeah. Got an outside force out there on that lever. So, help me out here. What kind of motion is going on there? Active? Active assist? Passive? What do you call it? Self-assist? It's an external force. Or it should be. Right? You got to know how to do and instruct proper pendulums. If the PT sees you doing these wrong, they're going to chastise you. If your supervising PTA sees you doing these wrong as a student, they're going to give you a hard time. It doesn't happen at the shoulder. Now, if you're still not sure what we're doing here, if it's kind of like, I don't quite know how to get let's talk. Or go see one of your peers and say, hey, look, I noticed that Kendall said you was doing a good job. So don't go to Donnie, Sarah, Rosie. Sorry, I'm just kidding. You gotta be able to teach those pendulums. These are critical because they'll pop up here at the next, at the next, at the next. Pendulums are just what we do. We teach those. And once you finally get into the hang of it, it'll come easier for you. But you really got to get that hip to say, okay, I'm going to move my hips, but I'm not doing this, right? Does this look like pendulums? It looks like pendulums, but it's not. This is active flexion and extension of my shoulder, right? This is active horizontal ABA deduction of my shoulder. There's another one, and that's circumduction. Right? You see my hip throwing my arm out? My hip throwing my arm out. I got major problems. Put a little bit of weight. Water bottle works great. Whatever you got. All right. Let's jump into this one. The management of the controlled motion phase. Here we're back with a pain, edema, and effusion. But it says here we're going to use functional activities, but we're going to monitor them. And then it says this, range of motion. Range of motion for glenohumeral and scapular motions is progressed up to the point of pain. The patient is instructed in the use of self-assisted range of motion technique, such as wand activities. Here's our wand. So here I am. Let's make it my left. To the point of pain. Ooh, okay. Right, and I'm using my good side. This is where the self-assisted comes in. I'm using my good side, and I like to teach them to use it from the middle because you get a little better leverage. Your lever's a little better right there. Okay. So there's flexion. Here's abduction, right? Here's external rotation. All the motions, but in the control motion phase, are going to pain, i.e., we're stretching tissue. You get it? We're stretching tissue. It also says here that we can also use hand slides on a table. Another activity that we really like to instruct on is called the table stretch. And what we do is we put them in a chair and their hand goes out here on the table. And it's just as simple as moving their hand out here. Well, right now I'm at 45 roughly degrees, would you say? About 45? Okay, and all I'm going to do is I'm going to slide back in my chair. And now where am I at? I'm creeping up there, getting real. I mean, I passed 90 fast, didn't I? Right? Because I use my trunk to turn instead of my arm. And so, again, going to the point of pain, that's stretching. Yes, sir?
Would you put them in like a rolling stool for that?
You could, but I'm going to go off of the Jerry Hobday rule of we don't put our patients on stools.
Also, how do you feel about doing it on the wall?
Great question. Exactly where we're going to go next. So we've transitioned from here to the wall. On Wednesday, we'll see a ladder, and you guys have seen it before. It's the finger ladder, right? And that's a great tool to use for that. Again, we're working abduction and external rotation. Those are the two weak links. But also, I would say flexion is a big part of it too, right? So wands, walls, tables, boom. Now I've got a stretch technique that they can do. And here's the deal. Self-assisted is probably the biggest part of it. So when you're writing your HEP, it's all self-assisted stuff, right? Because here's the deal, I can go into my patient, put them on a plinth, and I can stretch, and I should, and then I can come in and I can do grade 1s. Hang on. Here's some grade 1s. Here's some grade 2s. Okay? And we're going to teach you those on Wednesday as well. I can do those, but they can't. What can they do? They can get on a table, they can get on a wall. There's the pulleys, which who knows where our pulleys are. Man, I can't keep up with those things. I guess people just like them when they're having fun. But you guys know what I'm talking about. Most of you in outpatient have seen the pulleys, right? Was that a big part of your shoulder stuff? And that's a really good one too, because it can take them right up to the point of pain, so they can stretch. Abduction's really easy to get there, right? So that's our big part there. It says, with increased pain, I'm under precaution, with increased pain or decreased motion after these techniques, the activity may be too intense. So that's your judge all the time. If you do this and then they kind of go backwards, you did too much. And so you got to back off a little bit. Another unique thing is when my sister-in-law fell to her post-COVID adhesive capsulitis, what I said was, let's start back with the things that we've done before. And I jumped her right to Codmans. And it looked like homegirl had never done Codmans in her life. I mean, she was just like, oh, this hurts. And I was like, no, you got to use your hips. And she's like, ah, this hurts. And I was like, no, you got to use your hips. It never got in here. Some people are really psychosomatically dysfunctional. And I don't mean that to discount those folks. What I'm saying is it's really hard for their brain and that body part to connect. And so when that happens, you have to revert to your strengths as a therapist and say, okay, we're going to do passive range of motion. I'm going to do that for you. Right? That's what we're going to live on. And we're going to do isometrics, and we're going to do that a lot. And so I'm going to come see you, or you're going to come see us a lot in the beginning. And once they get to the point where they're managing that, and they do learn how to do that pendulum exercise correctly, then you release that back to them. And that's just what I had to do. I said, it pains me to say this, but you're going to have to come to my house every day. And like, I just don't want visitors who come to my house every day. I mean, any one of y'all can come to my house anytime you want to. It's fine. Don't take that as me telling you not to do. Carter, if you want to come over for dinner tonight, you come over. But what I'm saying, we're having chicken and salad and leftover beans, and they weren't that good. You may not want to come over. But what I'm saying is, she's gonna have to come, and we're gonna do this every day. Like, we're just gonna have to do this every day because she's not gonna get the care of her. Moving up to grade 3s. Take a look at some of these self-mobilizations over here on 549. Everybody grab your chair underneath you and pull, pull, pull. And look at that. That's called a caudal glide, where the humerus is going down. You really have to get kind of more to that side table. Manual stretching, again, that's just with our table or a wall. And then, I really like this one over here on page 551. And I want to show you how to do this one. It's called a towel stretch. Some of you have seen this one before. The way I like to do this, though, is I like to instruct the patient to take the towel in their good hand, if they have one. Like, that's a reality, too, is they may not have a good arm. You take the good arm, and you pass it along over the head. And then you just take what you can, and sometimes these people, they really have to fight to get back there, right? Because reaching in their back pocket, that internal rotation may be too bound up. So you let them grab, right here, right? And then they just kind of work it up, and then you take that good arm, and you stretch. Now, that stretches into internal rotation, right? So, let me take a step backwards. There was a question in our weekend course where Teresa showed you this test right here. and then that, right? Okay, and that was looking at if a person has internal rotation. Do you see that? Well, this only stretches a person in internal rotation. So it's a good stretch to use too. It's demonstrated on page 551. And then in the return to function phase, it just kind of jumps into a few things, but we really focus on flexibility and strength. Now I'm going to hold right there because I'm going to demonstrate some of those things on Wednesday. I do want to jump into the next slide though, and that is this right here. Sometimes our best efforts just don't work. And that patient has to go through what's known as a manipulation under anesthesia. It's called an MUA. You've probably heard of these before. This is really common with this condition right here. This was the best picture I could find on the internet for it right here, because this cat is out, right? He's under general anesthesia, but they're not scrubbed up because they're not opening anything. But they're taking the shoulder that at its best was like, there it is, there it is, there it is. And the doctor says, okay, put him out. And they say it's a terrible sound.
Let's say, is that like
Bill
a
said he
video
done
on
it.
YouTube?
But y'all remember that when Bill said he accidentally done it to that one? She had adhesive capsulitis, I believe, and he took it all the way past, and he said it just big rip. He said it was his first year too.
Man, Bill was mean.
He said the woman kept telling him to go, and he's like, "You sure?" But then he said, all of a sudden, you just heard a big snap.
How did you do afterwards, I wonder?
He said it was better.
Oh.
It hurt when it happened.
And they do that. That's a thing. I also know that they do that sometimes with knees when they cannot get flexion. They'll put them under and pow. In fact, Jacqueline, one of my patients, she's had to do that her first go around. Just some people just can't tolerate the treatment, or they don't do well with it. It just doesn't work. Who knows? But that's what an MUA is. So if you ever hear that term, MUA, manipulation under anesthesia, talked about on 551. Yes, ma'am.
So you can get adhesive
Capsulitis?
after early joint replacement.
Yeah. But it's probably not that. It's probably not the capsule itself. It's probably other scar tissue coming around it. But yeah. There are a lot of total knees who they just haven't done very well. And so the doctor will bring them in, put them under. I mean, it usually doesn't go to the OR. It's done right there in the physician's office, one of the clinic rooms. They just,
Does that hurt worse than the first surgery?
it's pretty painful, I'm told. I don't ever want to know personally, but I know that the ones who I know who've had it done say it's bad. So glad you brought that up, because turn the page and look at 552, because it says post-operative treatment for an MUA. Arm is kept elevated overhead in abduction and external rotation during the inflammatory reaction stage. So let's just see that. It says the arm is elevated overhead in abduction and external rotation. They like leave you here. How long is the inflammatory period?
I mean, for that long, like that? Wouldn't it like go around? Mine would.
They cast it? I don't know how they think they
Sometimes they just keep it there.
They may make you lay down, supine.
Yeah.
But what they're going to do is they're going to assure that the scarring that takes place after that does not bind you down. Therapeutic exercises are initiated when? Same day. And the emphasis is on internal and external rotation in the 90-degree or higher abducted position. And they may be kept in in abduction for 3 weeks after the manipulation and sleep. So that's a real deal, man. That one, we really want to avoid that, but it does happen.
What kind of exercises would you do on the same day?
Passive and isometrics. Because they're in the acute phase again.
What else?
How do you check out the time? With just
Well, in that case, they're not gonna be in the same patient setting block. So you're probably going in acute care at that point, or you're in the hospital setting. I mean, I don't think they'll keep them overnight. They'll say, show up for therapy tomorrow. And so I guess you drive to therapy. I don't know. I think it depends a lot. I've never seen one that they've made stay that way, so I don't know. Bill would have to speak to us about that one again. All right, so let's do this one real fast. Acromioclavicular and sternoclavicular joints. I did touch on this a little bit ago, a little bit beforehand, and I just want to say this. As far as the AC joint is concerned, the acromioclavicular joint, it definitely can be irritated, and it talks about the overuse syndromes of the AC joint. And it gives some very unique things here, such as with grinding, packing, assembly, construction work, repeated diagonal extension, adduction, internal rotation motions, as when spiking a volleyball or serving in tennis. What we're talking about are overhead movements, right? Anything that can be done overhead. My brother, he's a very good auto mechanic. He does a lot of stuff overhead, right? He's gotten better at dealing with it, but you can just irritate the joint. Now we're talking about the joint. Now on Wednesday, I'm going to talk about the tissues that can sometimes, and it's called impingement syndrome. So there's two different sets here. The other one here, subluxation or dislocation. I need you to walk away from today's talk knowing that yes, that bone can, by definition, displace, which by definition is a dislocation. However, you're not going to hear it termed that way. In healthcare, specifically orthopedics, they are going to reference this as a separation. And it's really nasty to you guys as students until you get this down. By definition, the bone has displaced. It has. But they don't call it the dislocation. Because when you hear the word shoulder dislocation, that is always depicting a glenohumeral dislocation, where the humerus displaces from the glenoid, stretches a whole bunch of tissue, right? We already know this. And then it lands, the posterior aspect of the humerus lands on the anterior rim of the glenoid. We'll talk about that one on Wednesday as well. But this is not that. This is the clavicle has ruptured. And you can see the ligaments in this picture, right? So you got the acromioclavicular in a type 1, but then you look at those other two ligaments over there in type 2 and type 3. I have personally a type 3, and it's probably hard to see, but I have a type 3. I crashed a bicycle years ago. Well, not years, 3 years ago. And landed on my shoulder, broke my clavicle, and that didn't hurt near as bad as the AC joint separation did. I broke a clavicle in my first rib, and the AC joint separation was way worse. That's all I wanted the drugs for, was the AC separation. And I thought it was going to be bad enough that I was going to have surgery, but they said no. You just have an ugly clavicle now. So it's the way it is. And then last there is the hypomobility, and that is a decreased clavicular mobility may occur with the SC joint, osteoarthritis, and may contribute to a thoracic outlet syndrome with a compromise of space of the neuromuscular bundle as it courses between the clavicle and the first rib. So if the clavicle is hypomobile, now think about it like this. The clavicle, it has a little bit of rotation to it. It has some tilt to it. And so those two things have to happen. But remember, it hinges off the SC joint. And so any one of those areas could lock down for whatever reason and cause a thoracic outlet syndrome. So those things just kind of fall into place there, and that's just kind of, as the student, what we have to look at. Questions on any of that?
Subluxation, I could have sworn that meant it like went out and then came back.
It does.
Okay.
And that's what I want you to really kind of rely on is in our clinical settings, you just won't hear it said that way.
Okay.
You're going to hear everybody from the doctor to the PT to the other PTAs, they're going to say, oh, they have a shoulder separation.
Okay.
And they're talking about the AT joint.
Okay.
Dislocation is always in the, I know you girls went clinical. What the book is trying to do is to stay very academic and say the bone is displaced using the term subluxation dislocation.